Good afternoon, everyone. Thank you for joining us again this evening at Caribbean Diaspora Vibes. We are so excited for this awesome awareness that we're going to bring to you this evening. But before we get started with our guests, we want to just say hello. Hello, Dr. Bevan. How are you?
Good evening. Good evening. Once again, welcome to another Saturday Live Vibes, where we educate, we mingle, and have fun at the same time while we're learning. And today is another powerful series from last week. So
Right.
stay tuned and just be empowered as we keep inspiring and hoping that our viewers and listeners gets help.
Yes, this is all about bringing awareness to our community. And, each month we have different topics. And this month, oh my God, May has so many different focuses. We're not always able to address all of the awarenesses, right? But we wanted to address COPD this month, this busy May. And we are actually blessed to have um, Deanna Rollyson. I always want to call her because she looks like a teenager, So,
Thank you.
so, but I have to remember she's Mrs. Deanna Rollyson, who's actually Mrs. Sarasota, America, and she's a COPD advocate. And we get to hear how did she become a COPD advocate, what happened in her life, and how she's dealing with it now. So we're going to turn this over to Deanna so she can inform us because I don't think many people even understand, D is chronic obstructive pulmonary disease. And many of us don't really know what that is. So thank you, Deanna, for just joining us and blessing us with this information.
Sure. Thank you for allowing me to be here. It's my honor actually to be here and have the opportunity to share the awareness for COPD.
So tell us a little bit about who Deanna is, because we see this gorgeous picture. I know we're here to help wearing this, but we cannot help the beautiful picture that we have. So give us a little snippet about who you are and your journey.
All right, sure. I am born and raised in a little town called Plant City, which is the winter strawberry capital of the world in strawberries. So if you've ever tasted a strawberry, you probably have actually had a little taste of our little town here in Plant City. I moved to Sarasota about 2 years ago with my husband, Ken, and we've been married 37 years, and we have 2 grown children and 3 granddaughters, actually. And growing up, I came from the little town and my parents had limited education. Neither one graduated high school. They got to about 6th grade and both my sisters dropped out. So I knew early in life I wanted to do something different. I wanted to make something of my life. I actually wanted to graduate high school. So I started working several jobs and worked at Dairy Queen to put myself through high school and worked 2 other jobs to put myself through college. And when I graduated college, I founded a company called Matrix Medical, which is in the respiratory business. I grew that to 9 locations and about $20 million. Sold it, consequently, sold it to a company that I became an owner in. And have grown that company into a $800 million company. And they actually sold this past February. So I worked for my new company called Adapt Health. So I've been in the respiratory business for a long time and just kind of stumbled into it, believe it or not. I set up my first patient with oxygen at Matrix Medical about 15 some odd years ago. Set him up in his home with his oxygen. And, later in life, I actually got diagnosed with COPD. So and that's just been a few years ago. And right now that has fueled me for the last few years to become an advocate. The whole idea of having a disease that isn't curable, that's progressive, and when you got grandkids that you want to see grow up and you want to see your daughter one day have children, it kind of motivates you to do something in life that's different and make a difference. So I'm proud to be an advocate for COPD. I'm proud for the work that I've done. I'm proud for my physician, Dr. DeWuji, who is joining us, who is keeping my lungs healthy. And I'm looking forward to, sharing even more.
Wow, so you have been in the health business, especially in that business for quite a while. And
Yes.
and you said 37 years married. Oh my God. Like I said, you barely look 37, yeah.
Child bride.
You're beautiful. Thank you.
Thank
So the
you.
very thing that you were helping with, you got diagnosed similar. But you mentioned, I think you started out having asthma.
I did. So probably about 10, 15 years ago, I was diagnosed with asthma and, quite frankly, didn't give it a lot of thought. I was in the industry. I knew what an asthmatic patient looked like. It didn't look like me. So, I kind of was like dismissive, took my medications when I wanted to, and, had some, slight exacerbations here and there, not a big deal. But it progressively got worse. And in the last few years, it actually got even worse to the point where, obviously Dr. DeWuji had to make sure that he stepped in and put me on a better regimen of medications and made sure that, I'm following his instructions. But yes, it started all with just asthma.
Wow. So we definitely need to be careful then. So tell us then, and we're looking forward to your presentation because your story, your journey is very interesting, and I'm glad that you were able. It's always good when someone can turn their mess into a message.
Right.
Exactly what you are doing is mess into a message and being such an advocate. And it's not like you just started this as with the competition or anything like that. You've
Right.
been on this road many years.
Yeah, COPD is my platform as I represent Sarasota in the Mrs. Florida America pageant. But it's more than that. It's bigger than that. It's my life. So it behooves me to do the most that I can to help find a cure, bringing about awareness. The COPD Foundation has asked me in Florida to represent them in Tallahassee, which is kind of nice on some of their fundraising and funding initiatives. So I'm looking forward to that if I become Mrs. Florida, and working closer with American Lung Association as well on some of their walk, climb for air and different types of walks and promotional things that they do throughout the state of Florida. So there's a lot to be done and a lot of awareness to be made.
Yes. Well, you're just the perfect person for it.
Thank you.
Yeah, so let's get started, Deanna, and tell us what we need to know, what we need to look out for our family and friends.
Sure. Okay. And I have Dr. DeWuji on the line. So I'm not a medical. I don't have a medical degree. I have a communicative sciences and disorders degree, but not a medical degree. So I will be asking Dr. DeWuji to jump in when he can, because I think for clarity reasons, I want to make sure that the questions are answered appropriately. So I just put together a bit of a slide presentation for those and that have interest in understanding COPD, and I put a little bit about asthma in there just to bring about awareness. So it's it's in layman's terms, but and anyone can understand it. So I'm going to share it with you. All right. So obviously I started off just talking about the respiratory system and obviously recognizing the lungs and the organs and where they're located in the body. But most importantly, there is the bronchioles and the alveoli that are part of the respiratory system. So I wanted to make sure that I said something about that, because some of the different types of effects on the lungs, occur in the alveoli, and some of them are in the bronchioles and some of them in the branches. So it does make a difference to kind of know what you're looking at. And obviously the inspiratory phase is obviously the diaphragm pulls in and the muscles contract. And obviously the work of breathing is brought in, and then the chest expands, and then you expire out. So there's pressure increases in the lungs, and the air is forced out on the expiratory phase. That's very simple stuff, and pictures are, very elementary, but there is a lot more to breathing than just that simplicity. But COPD my definition, the things that I pulled off of the internet, but it is a disease that's characterized by the airflow limitations. And so the airflow limitations is progressive, and there is no cure. And it does, obviously, when the lungs are unable to expire correctly, there can be due to, obviously inflammatory type of issues, mucus and sputum and buildups and et cetera like that. There is a stacking of gas that is dangerous for the body if you cannot get the expiratory phase to complete. So it's usually, I think stage 3 or 4 is usually where that's occurring, but I'd rather ask Dr. Dewuji to jump in and tell me what his definition of COPD might be as well.
Well, we'll wait on Dr. Dewuji.
All right.
And we'll
we have them unmuted.
Go on through.
Okay. All right. So obviously the causes of COPD is inhaling pollutants, things in the air. Smoking is the number one. Cigars, secondhand smoke's pretty predominant. My parents did smoke earlier in my life, but not long term. So that's usually the leading cause of COPD. Fumes, chemicals, some people have jobs and things like that sometimes are subject them to some environmental issues. And genetics play a slight role in that, but it's more about the irritants and things like that in the air. And you can get tested these days for genetic predisposition. So I'm going to talk a little bit about that too, which is kind of cool.
So
hey, I'm sorry, I didn't realize there was a mute button there. Can you hear me now?
Yes, we can. Please help me out.
Okay, so basically what Deanna said about COPD is correct. It's a functional disease, but it encompasses a lot of clinical diagnoses. So COPD basically we define by pulmonary function testing, and it's most commonly associated with tobacco smoking, but that's not the end all be all. As Deanna mentions, asthma, when it's not properly treated and it's chronic, can develop scarring of the lungs, and that can also be defined as COPD. Secondhand smoking, any pollutants or anything that scars the lung basically affects its function. And when you have a fixed deficit, that's what we defined as COPD. So emphysema, chronic bronchitis. Now, chronic bronchitis is an exception because you may have normal function, but you have production of sputum and a cough. That, again, is a chronic functionally lung disease. So we define it as a chronic lung disease, but not necessarily a COPD when assuming for insurance purposes. Now, the new gold definition means that you have a fixed deficit. So COPD, by that definition, means that you have a permanent scarring of the lungs, right? But when we talk about it clinically, asthma, chronic bronchitis, bronchiectasis, emphysema, they are all defined as COPD clinically. So when I talk to my patients, I talk of two definitions. One, a functional definition, and two, a clinical definition. Does that explain it?
Wow.
That's good. Thank you. Far better than I did. I will say that the first time I actually understood I had a lung disease and or something wrong with my lung was when I was applying for my very first job, believe it or not, out of college, and they sent me for a lung x-ray, and they told me that I had scarring in my lungs. And I was very confused because I had never heard that before. And since that time, I think I've had several scans and et cetera. And yes, I have scarring, but I apparently had scarring, way back in my early 20s as well. So I'm not really sure where that came from, but I'm sure I must have had something prior to I was subjected to. I put in
smoking.
Secondhand smoking, yes. I was around secondhand smoking. My grandmother smoked like a freight train, but she lived till she was 90 years old.
So that is real, the secondhand smoking, because you think, well, I don't smoke, but the secondhand smoking and wow.
It's the
Well,
only thing that we can trace back to me, to the best of our ability.
in America, the most common cause of COPD is smoking. Worldwide, the most common cause of smoking as a COPD is wood smoke. And most commonly women get it because they smoke over open fire. They cook over open fires.
Fire. Mm.
Hail the smoke from it.
Mm.
Oh. Wow.
Very, very interested.
Well, I did, Dr. DeWuji did mention the lung function test. I did throw in there my lung function test that I did this week. And obviously once a year I go have my lungs checked. And this is just to show you what kind of booth, if you do a full-blown PFT, the simple spirometry can be requested at a physician's office. Your primary usually has a unit there, but those are the two ways, as he spoke before. There is an alpha-1 type of measurement of proteins in the body that's now available through a blood test, I believe, Dr. DeWuji, that shows if you have predisposition of potential COPD. So that's also something in the last probably 5 years, maybe, that's come about and allowed for testing for this disease.
So you're just 20-something years old, and then you go in for random testing for your job and realize that you have scarring. Now, is this scarring, is this something, so that's not reversible, right?
No.
Any scarring is not reversible. A scarring by definition means that there's a permanent fibrosis. But the lung has a lot of redundancy, a lot of reserve. So you should theoretically lose at least 30 to 40% of your lung function before you can be defined as COPD by functional definitions. But if you're defining it by clinical definitions, that's a different case scenario entirely.
Wow.
And functionally, I'm doing relatively okay. So I try to make sure I take my medicines and do the necessary inhalers and nose spray. So functionally, I'm trying to keep my lungs exercised and expanded and as healthy as possible these days. One of the things I did put in here is recognizing it is the third leading cause of death in the world. It's estimated about 30 million people in the United States actually have COPD, and there's about 16 million of those that don't even realize it because it's one of the most underdiagnosed diseases out there. It's the third leading cause of disability in the United States, and it's the third leading cause of hospitalization readmission. And it recently ranked this past week, I believe, by the American Lung Association as #1 cause of death in 2021. Obviously, that was due to a lot of COVID. And it's affecting women at a higher rate than ever. So yes, Dr. DeWuji just spoke of that a few minutes ago, but that's one of the prime reasons that actually motivated me to get more involved is the rate for women was climbing. It's pretty staggering when, you don't know if you're going to be able to see your children grow up. So I got very involved when I started reading some of these statistics years ago.
And I wonder why the rate is going up.
More of awareness, that could be one thing. If people know about it more and people are getting tested, then the numbers will climb. I was going to ask a question in reference to you talk a lot about the fire, the burning, the wood scar, etc. And that big percentage that Ms. Deanna, you just listed as individuals who died of COPD. So we heard of COPD a lot after 9/11, and we know why. And then again during COVID, and we know why. So in between those incidents, were people dying of COPD but diagnosed to die of something else? Something like when AIDS, and people were dying of AIDS, and they would say, they gave it a total different name. You didn't die.
Yeah. there's quite a few comorbidities that are associated, obviously, with that death rate. Lung disease in the American Lung Association classifies COPD as a lung disease. So when they say last year, 2021 was ranked #1 in leading cause of death, they are putting lung disease in there, and that could be, and I think bronchiectasis is even considered in that. That's probably not something that probably was high on the diagnosis, but COPD, lung disease, emphysema, chronic bronchitis, those are the most susceptible to, COVID and not getting and making it through. So I think that's why the numbers were so high. And I think the numbers are rising because in the last probably 10 years, vaping is really big. Vaping is a new thing. And obviously many states are legalizing the medicinal use of marijuana in different forms. And so there's a lot more going on than ever before. And it's almost, acceptable, but it's the same result. It's the same result. It's going into your lungs, and it's not normal, air exchange. So that's why I think some of the incidents are actually being reported at a higher level, because it's actually young people are being diagnosed earlier as well, not just women these days.
Okay, thank you. Good.
Yeah. And what does your typical day look like with having to deal with this?
The days change. There's not really a typical day. There'll be some days I wake up, I'm breathing perfectly fine. The weather conditions are perfect outside. The humidity is not, heavy on my chest. And I'm breathing okay. I go ahead and take my inhaler. I take my singular. I go ahead and do my regimen of medications, and I'm great. I have, a little cough every now and then, and then there's days I wake up, to be quite honest, and I can't get to my inhaler fast enough. The congestion, the phlegm, it sounds like I have pneumonia, or it'll sound like I have a bad case of bronchitis. It's how thick and heavy my chest can get. And, it's not very beautiful. It's not nice to talk about, but it is part of what I manage. And, I can have an occurrence anytime. The other day I had, a bit of an asthma attack where my airways, I could tell they were shutting down because I was around a particular lotion that someone had put on their body, and it was heavily scented. So immediately my airways started, shutting down, and I could tell I needed to, step away from that person and get my inhaler ready, if you will. So honestly, the days vary with the weather conditions, what's going on overall outside. That has a lot to do with who I'm around, because people are predominantly wear a lot of perfumes, and people love candles, and they love the plugins in the walls, and all those things set me off. So.
Right. Okay, Donna, let's allow you to continue the video or your PowerPoint, because maybe you have some of the questions that we're going to ask will be answered there. I'm reading as I look, and I have some questions, so maybe we give you a chance to complete that, and then we get back into some more dialogues.
Sure. I mean, I don't have too much more, except obviously the importance of assessing it. The most important thing I wanted women especially to recognize is that if they have a chronic cough, or they have a tendency to be clear in their throat a lot, or have a little heaviness in their chest, or shortness of breath, just going short distances, they do need to request a spirometry. If they're not, seeing a pulmonologist at any time, they should always demand to have their lungs checked. In society, we do have, our breast cancer awareness. So we're always talking about the yearly checks, or the men going and have their yearly checkups. And we talk about, a healthy heart, but we don't talk about a healthy lung. So one of the most important things I want to convey to women today is that get in there and demand a spirometry. Ask that doctor, I'm your patient, I want to have a baseline for my lungs, if you will. So, and obviously we've already talked about some of the things to reduce is to stop smoking, exercise more. I do play tennis, and I work out for that reason. I hate working out, despise lifting weights, but I do those things because I know it helps my lungs expand. and it's going to help me live longer, to be quite honest. So improving exercise tolerance, obviously removing barriers that set you off, and set off asthma attacks and or the airway reduction, remove those from your environment, and just, overall make sure you have your medications with you as well. Once you're diagnosed, it's when you have to have all your medicines with you at all times. So you just never know. And then that's really it. We talked a little bit about asthma, but I have a little thing on asthma, but Dr. DeWuji did a great job talking about that. So that's really what I have for my COPD portion.
Nice.
Wow.
Good job.
Dr. DeWuji, you still there?
Yes.
Any
Yes.
recommendations?
I'm sorry?
Any advice you would give someone, a young person?
Well, we don't think of COPD as just a disease of the lung anymore. We think of COPD as a disease of the body, a systemic disease. It affects everything. You see people with COPD suffer being malnourished because the work of breathing is increased. You people COPD with having more heart attacks, etc. Because it strains, it causes strain on the heart as well. It accelerates deterioration of the whole body. So we have to think of it not just of the lung, but of the body.
Wow.
And COPD is not only associated with tobacco smoking, although it is the most common cause in the developed world. We have to think of COPD as an environmental disease. Pollutants that affect us on an everyday basis as well will affect the lungs. Anything that you inhale, as Deanna mentioned. What else can I say? The earlier diagnosis is very important. Early appropriate treatment. It's an irreversible disease. It's a progressive disease. Those things we have to bear in mind. And again, as Deanna mentioned, you don't exercise the lungs, you exercise the body. So you develop secondary functional capabilities that will compensate to a degree for the loss of lung function. You can never recuperate the lung function, but you can develop and condition your body to tolerate the effects of COPD better.
Man, thank you.
If you are educated about it.
Could you elaborate a little bit more about the emphysema?
Emphysema, well, think of the lung as a sponge. Mm-hmm. When you get a brand new sponge, there's lots of little holes.
Yes.
Right. As you use the sponge, those little holes become bigger and the lung loses the elasticity that it had before. Right. So the lung behaves in a similar manner when you develop emphysema. Emphysema means that alveoli, as Deanna mentioned, which are very microscopic, coalesce, join together and become bigger and bigger. So the holes in the lungs become bigger and bigger, right? Until they call bullae, right? Not alveoli. And because of that, the lung loses elasticity. And in the end, as they lose the elasticity, they develop what we call breath stacking, which is something else that Deanna mentioned. And therefore, you lose some expirational capacity, what you call air, you get what you call air trapping. Mm-hmm. And that can be overcome to a certain extent by the inhalers. Now, when we talk about inhalers, we don't have, when you talk about treatment of COPD, we really do not have many options. We have what we call beta agonists, like albuterol, and we have anticholinergics like Spiriva or ipratropium. And basically, all the medications that you get in the chemists, in the pharmacies, are on these two basic groups. And all they do is bronchodilate, meaning expand the airways to a certain extent to relieve the air trapping and allow you to exhale properly.
Yes.
Right? So that's the those are the two treatments we have. Now there are other medications, long-term medications like steroids, etc., but we tend not to use them too often because they also have immune suppressing effects in long term. Now, combinations of those drugs can also be beneficial, and education on use of those medications should be performed properly by a properly trained clinician, either a nurse practitioner or a physician. But that's very important because generally speaking, patients that I see in practice are not educated on the appropriate use of those medications, use them haphazardly, and think they're doing the right thing. And unfortunately, that's not generally the case. And when we get these patients, they have advanced COPD, and we have very limited options in those cases.
And I think that
And as
that's
I
one of the
mentioned
big-
again, it's a systemic disease. So muscle conditioning also, if COPD is not properly treated, you lose muscle conditioning. And that's where physical activity training is important. Unfortunately, most of our COPD patients get into a vicious cycle where they can't breathe, they don't exercise, they get weaker, and so on and so forth.
So what I'm hearing, Doc, it affects, we talked about earlier about the inflammation, then you mentioned about the physical health. Does it have any skin of age, anything that affects the skin? Anything that you can see besides those other?
No, not that I know of.
Okay.
Of course, you get nail clubbing, you get cyanosis, things like that, but those are in extreme cases.
Okay. That was the next question. When you said, if it's not treated, it gets to a higher stage. I wanted to ask, what does that higher stage looks like?
Well, there are two basic characteristics of COPD. You get the pink puffer and the blue bloater. So that when you think about the pink puffer, you're thinking about the patient that he has chronic bronchitis, and the blue bloater is a patient that's emphysematous and has some evidence of cyanosis. So emphysematous patients generally have a higher work of breathing, and they lose a lot of weight, they become skinny, etc. So if you look up on Google and you look up pictures of pink puffers and blue bloaters, you'll see patients that are pink puffers are basically patients that are somewhat overweight and have a lot of coughing, etc. Whereas the blue bloaters essentially are very slim, cachectic patients and are mildly cyanotic or very cyanotic, basically because their lungs aren't capable of absorbing enough oxygen from the atmosphere. Because loss of lung also implies loss of the capillary bed, the vasculature that absorbs oxygen into the body.
Wow. Deanna, can we see the slide with the lungs because it's so interesting to look at I think there was before.
This one. This is just showing you the normal airway and then the constricted mucus filled airway, usually associated with asthma. That's usually what I struggle with a lot is the mucus in the airway, always the clearing of the airway for me. Because obviously I still have that component, probably back here or
second or third slide.
This one?
Yes.
Yes. Yes.
Okay.
Actually, the one that you just had showing, okay, so the one that you just showed with asthma, so you showed it was like clear, and
it's a blue one.
Then you had the and then you showed the difference between the two airways. Is that the same for I guess for all of them for COPD also? That kind of like the heart, this one. The normal airway is just wide open, and then the other one, whether it's COPD. Is this similar? Would it be constricted like this?
Well, I think that's what that black spot is is where the mucus is forming, right? That is a congestion area.
So the mucus is forming in the bronchial, like the tube areas, like in of
tube.
course, obviously the doctor speaks more clinically than I do.
Right.
But the bronchial tubes is where most of the mucus is formulated and becomes obstructed. So where it's normally open, it becomes obstructed and gets tightened. And a lot of times when when someone has an asthma attack, which I've had, it gets so tight, your upper airways and your bronchial tubes up here, like everything's shutting down, and you're pulling air through like a straw. It's how tight it can get. Now, it may not be mucus filled, and Dr. DeWitt can speak on behalf of that. It may just be the complete constriction of it as a reaction. But this is usually what, asthma is usually just like a lot of constriction, and it's mucus based, and there's a lot of, and so is COPD as well. It's just a matter of what type of reaction you're having or to the asthma part or the COPD part.
So not all COPD patients produce mucus. Patients with emphysema predominantly don't produce mucus. Patients with bronchitis or chronic bronchitis will produce mucus, but you don't get a pure emphysematous disease, and you don't get a pure bronchitic disease. Usually there's an overlap between this. Now, just for clarification, I think I misspoke earlier. A blue bloater is essentially associated with chronic bronchitis, and a pink puffer is associated with emphysema. So you will see characteristic patients like that, but they don't have one or the other. Now, when you get an exacerbation can be defined by a number of things. One, the more increased work of breathing and more shortness of breath. Two, increased sputum production. Three, with chronic bronchitic patients, there may be a change in the characteristic of the sputum. Three, it could be fever. So there's a lot of different definitions of an exacerbations. And as just like the spectrum of COPD, COPD can be associated with asthma, which is chronically not being well treated or not looked after. It can be associated with bronchiectasis. It can be associated with recurrent pneumonia, which can cause scarring of the lungs and therefore decrease the functionality of the lungs, right? So what usually happens with COPD is you lose both alveoli and you lose the capillary bed, which is the blood system that circulates in the blood, in the lungs.
Yes, I think in the COPD side of it, I can speak on behalf of, obviously the oxygen exchange is the most important thing that's not occurring as the disease progresses. So usually those patients that are stage 3 and 4 are usually ending up on oxygen. Obviously the alveoli, say it for me, Dr. DeWitt. Alveoli, it's like you said, like kind of like loose, and it's not able to get the oxygen exchanged correctly. So obviously the carbon dioxide is not being pushed out of the body. And I say dioxide, is that right? It's not being pushed outside the body, and it's stacking inside. So that's when usually you have to have oxygen. A lot of our patients go on ventilators as well. So they don't have to be on ventilators all the time, but they can be on non-invasive because it helps the work of breathing, and it helps their lungs expand, and it helps the exchange, and it allows the lungs to be able to push out what it would actually stack of the gas that's the buildup that's bad in your body. And obviously any buildup of bad gases in the body obviously creates morning dizziness, confusion, and can lead to all kinds of different types of concerns. But overall, it's your body reacting to some type of gas in your body that ends up that is having a negative effect on you.
Just looking at this picture, it kind of opens your eyes a little bit to what someone would be going through that has even just asthma, right?
It feels like that right there. So
yeah. Because sometimes we just don't have the knowledge, and just seeing the one picture on the left, normal, just looking at,
and then this
to think that you're
tightening.
trying to just breathe and you just have this narrow. Um,
Yeah, it's a buildup, and you can feel it. You know, you can feel the buildup, and you can feel your airways, you know, tightening. It's pretty obvious after it's happened to you a few times. For me, it's obvious in most of my cases. So, and the chest gets very tight. The coughing is, you know, is out of control sometimes. And, you know, and you're bringing up what is, you know, clogging up your lungs, if you will. And your lungs are inflamed, you know, and they're not working properly. So, and I'm usually fighting to try to get it out, you know, because you feel like you'll feel like you're choking and or you're drowning, because if you've had pneumonia, you know, you have fluids, and sometimes when you breathe, you can feel the fluid in your chest and you're trying to get it out. For me, it's very difficult for me to keep coughing because for some reason I can't get my expiratory phase to push out. So when I cough a lot, and I cough hard, but I can't bring up enough stuff, you know, enough to make me feel comfortable. So it takes a while for my airways, once they start getting constricted or inflamed, to actually relax. I have to run to my inhaler, and then that still takes time.
Right.
We see people that can't, when they can't find their inhaler. I mean, I've only seen it in the movies, but that they could die. So I guess that's really,
it's like pulling air through a straw, and I don't even know how to explain it, except that it's a straw that is about as teeny as, you know, you can get your hands together when you have an attack. And if obviously the airway shuts completely down, I mean, you're going to pass out, and at that point, you know, someone's got to be able to get you to the hospital, or, you know, get you back breathing properly. But I've had 2 episodes where I got very close to feeling like it was going to be close to death because no one was around me. So I got really, really nervous, and, you know, just kind of leaned back and tried to control my breathing was the only thing I could do at that time, because I didn't have my inhaler, like you said.
Oh, yes, Miss Diana. I'm looking at the airwaves, and, you know, Donna was talking about the size, and it just boom to me.
Yeah.
Like when you have a sickle cell crisis, you know, how your platelets start to shape in a different, so now it cuts off that oxygen flow. So, and just watching that and making that connection, because I have sickle cell disease. So and a lot of the things that you mentioned, the inflammation and a lot of the acute pains and stuff that you experience is similar to what I experience as well. It's just that the vein, the blood flow is cutting off. This is not the lungs necessarily, whereas yours is the lungs.
Yes.
But
I used to use the analogy, it's like a train. Your body has a little train track inside of it, and the train tracks bringing in the oxygen, and then you got the next, you know, cart that takes out the oxygen. You know, it's like, if it's working properly, you know, it's like dumped in and your body gets rid of it. But if your lungs and your alveoli are not working properly, then your bad gases the exchange isn't occurring at 100%. So it's kind of like it's waiting there, but nothing gets pulled back in and out of your system. So it's and asthma is the same way. I mean, COPD, I think, is just it's just a very progressive.
Okay.
Is there anything that someone naturally could do or to prevent? Well, we know smoking is
right. Don't be fooled by the ads. It's don't be fooled by the ads is really what I always tell people. I mean, vaping is the same thing. You know, don't be fooled that, you know, even environmentally, when women are cleaning, you know, we're predominantly the cleaners, bleaching, mixing chemicals, things like that can also cause, you know, issues with the lungs over time. If someone's doing that routinely, there's just the smallest, there's so many things to talk about, you know, as it relates to what you can do, but just, you know, making sure you don't put yourself in a situation of that could cause an exacerbation. But if you do have any symptoms, The only thing I can say is we got to make sure we start talking to our doctors. We got to talk about better health for our lungs, and we got to start talking about if indeed we have a cough and it's chronic. At what point do we just let a doctor give us antibiotics? At one point, we're going to ask, hey, what is my baseline? What's a normal lung look like? Like we have to really be a little bit more aggressive in our fight and our awareness campaigns.
Yes. You guys mentioned earlier about the fire. I'm trying to think, is that for like grilling, barbecue, or were we referring to just cooking outside?
Cooking outside, no, cooking indoors, because most people in the third world actually cook indoors and over wood fires. But barbecue is just as bad because there's a lot of smoke coming from that. Any smoke that you inhale is bad.
It just stays there and sneak up on you slowly but surely. And
That's
when
right.
you talk about the chemical, I was doing a lesson on global warming today, and a lot of the things that you just mentioned, it's just amazing, with the dust and the mist and the pollution, and it's just powerful. It's just powerful.
And one of my platform is Breathing Better Today is a brighter future for tomorrow. And what I've done is partnered up women with COPD, that's progressive, and maybe are in stage 3 or 4, they're on oxygen, potentially on ventilators. And I have a group of ladies, and then I partnered up businesses and said, hey, businesses, these are women suffering, and, COPD among women lead to depression, anxiety, things like that. And, these women are in their homes and they're not wanting to get out. And I said, I'd like to provide them with a spa day, a day of beautification, something to make them feel good. And recently I was speaking with one of the patients that's going to the salt room. There's a new room in Sarasota called the salt room, and salt apparently has a way to help the immune system build as well as help the respiratory system. So she was telling me though that she got COPD from black mold, and she lived in a home with mold. And so sometimes you're in an environment you don't even realize. And she's very progressive. She's going to the salt room next week, and very excited for her to see if it helps her. But yeah, I was kind of surprised to hear that as I was talking with her and hearing about her story.
Is that sea salt?
It's a salt room. The walls are all salt. Everything in it is salt. I haven't been there yet. Wow. So it's a new way of therapy for the immune system. And so I'm partnering up some of the women that I'm working with to go to it. So the first one's going on Tuesday. So we'll find out after that. Yeah.
Sounds like a good detox.
Yeah, it does, doesn't it?
Yes.
Yeah.
But that's, really what I wanted to be able to, bring to the forefront today. And obviously Dr. Dewuji is more elegant and eloquent and, clinical than I am. I just know that there's a major need for awareness, and I'm just so thankful for the platform that you've given me and the opportunity.
Yeah, appreciate it. This is much needed dialogue, and we our job is to make people aware of what's going on, and always looking for the preventative ways rather than just stuck on the cure. What can we do to minimize, or if we have it, how, so that is the goal of this program.
Yeah, I always say COPD COPD isn't me. It's not who I am, it's
That's right. That sound like the rap. I got one too.
Yes.
I'm wondering, in the last 2 years, because it's about what we're inhaling, do you think that with wearing the mask that it would have slowed down what people were getting in naturally? Or
Dr. Dewuji, I'd love for you to answer that question, because it always felt like when I put my mask on, obviously I'm rebreathing a percentage of the bad gases that I've expelled. So, I'm wondering, Dr. Dewuji, weigh in on that. That's a good question.
That's not true. Most of these gases are designed to let air out and air in. Anything you expel, it doesn't mean that you're rebreathing anything. That's not true.
Okay. I always wonder that.
That's a fallacy from one of those media sites.
No politics.
Thanks
so
for
there
the
was
clarity.
So there was a protection then. There could have been a protection for wearing it for those that were at risk.
Well, we do know that environmental disease that was spread like influenza and things like that much less frequent in the last 2 years. So I'm
Right.
assuming that perhaps people that could have been exposed to extra environmental pollutants and could have developed COPD may be at less of a risk. However, that doesn't exclude smokers and things like that, because
Right.
people that smoked didn't really
They,
need masks to smoke, did they?
no,
Right.
could they?
Wow.
But it's just like even before COVID, doctors were wearing masks, and certain jobs that you did, you wear masks. So it's the same thing. You were put in that line of protection.
Right.
And
This
quite
is
frankly, I wore a mask the entire time. I've been wearing masks 9 times out of 10 where I go, but you know, and I did not get COVID. I was pretty surprised, you know, because obviously being compromised anyway. So, and I don't have any of the antibodies, so I'm still at risk all the time. So I do try to be relatively cautious these days, because you know it's still out there and still
Still
the
there.
yep,
That's right.
it still can occur. So
Yes. Awesome.
we definitely want to, yeah, for you to be extra careful, and for those that are, yeah, lower immune system, definitely still need to be careful. Wow, this information, we loved it. You know, the awareness went up. Again, ignorance sometimes keep us like where we don't really understand what's going on with
yes,
the person. So this, we have now, you know, that capacity to go, okay, I understand what he or she is dealing with, and even looking at within our own families to maybe say, hey, check on that, or this could lead to much
something
more damage. So definitely appreciate you taking the time out of your very, very busy schedule to educate us on this and to bring that awareness. As Caribbean Americans, we do a lot of grilling, lot of, all of that. So probably more than I would say Caribbean Americans, because we do a lot of jerk, right? We do a
yeah,
lot of jerk, this and that. So um, just looking at these little things a little differently.
right.
And so even though we're not probably doing it personally, our loved ones are the ones that's doing it, and so we just have to all just protect ourselves and realize that our health is important, and it's precious.
Number one. It's number one. That's right.
Right. Because without health, we have nothing. So thank you so much, Doctor, for coming on and joining us. We really appreciate you.
My pleasure.
Thank you, Dr. DeWishi. Appreciate you.
Now, Dr. Dewey, did you want to tell anybody? Are you able to say if they needed to find a physician like you, or is that not something you?
Well, not necessarily a pulmonologist. They should always talk to the primary care physician first if they have breathing difficulties, and then, of course, if those can't be addressed, then ask for a referral. Or generally speaking, most primary cares are quite competent dealing with COPD and don't always have to refer a patient. They only refer patients when they're having difficulties managing their patient.
Okay. And so any natural management is breathing, would that be considered, or breathing techniques, anything?
Well, what do you mean by natural? You mean homeopathic medications? I can't comment on that, because the homeopathic medications can have both adverse effects as well as possible beneficial effects. So there's different medications out there. I can't really comment on that. No.
Right. So, but
there are breathing techniques that you definitely can do. Yes.
Well, breathing techniques, I mean, as I said, the lungs per se don't really have muscles. You can't expand and train your muscles as people seem to think. What you do is condition your breathing muscles, your respiratory muscles, so you can develop those. And that's part of the COPD management, physical therapy, etc.
Okay. Good to know.
Of course, pulmonary toilet is another technique that people learn when we talk about pulmonary toilet, meaning people with chronic bronchitis produce a lot of sputum, so they can be taught how to effectively clear the airways, right? Breathing techniques like personal breathing when people have difficulties breathing, those are all part of pulmonary rehabilitation. So just getting a device on Google and using that and saying I'm strengthening the muscle, that's not quite what pulmonary rehabilitation is about.
Understood. Understood. Again, always important to speak with your doctor, and take the advice, and
Yeah.
I think before you get it, like I know breathing helps with anxiety and so forth, but that's a whole different level.
Right.
So good information, and again, good awareness for us, the questions of what to do, what not to do, what's suggested, etc. So wow, thank you so much. I'm so thankful that you were able to share it with us, Deanna. I really appreciate that.
Well, thank you again for the opportunity. I appreciate all the exchanges of emails and how pliable you guys have been. So thank you. And again, Dr. Dewey, I know you're not feeling very well today, so thank you for your time too.
You're welcome. Thank you. Bye.
All right.
Thank
Bye,
you.
y'all. Thank you. It's been
Thank
great.
you. Until next time, you've been listening to Caribbean Diaspora Vibes, and we hope that you share this information with your loved one, with your friends, co-workers, etc. Each one. So God bless. And Dr. Bavon, any last words? Oh, you're muted.
We'll be rooting for you for Miss Florida, right?
Thank you. Thank you.
Magic.
Yeah. I'll be posting something out there for the People's Choice, so people can actually go online and actually vote. So dial in, check it out.
Okay, thank
right.
you. Thank you.
All right,
Good luck.
everyone.
Good luck.
All right. Thank y'all. Bye.
Until
Okay,
next
you're
time.
welcome.
Okay.